Masturbation is one of those topics that tends to get discussed in one of two extremes. Either it's framed as completely harmless, a natural, healthy behavior with no downsides worth mentioning, or it's wrapped in moral judgment and shame that has nothing to do with medicine. Neither of those framings is particularly useful. So today, we're going to take the clinical approach. The question I want to address specifically is this: are there real physiological and psychological consequences to excessive masturbation? And does the risk profile change for men over 50? The answer to both of those questions is yes, and it's worth understanding why. We're going to cover 4 specific areas: how excessive masturbation contributes to erectile dysfunction, how it can condition premature ejaculation, how it can lead to anorgasmia, and what the broader psychological risks look like. Then I'll close with 4 concrete, evidence-based ways to protect yourself. I'm Dr. Claire. Let's get into it. Before we get into the specific risks, it's important to understand why men over 50 occupy a distinct clinical category when it comes to sexual health, and why behaviors that might be largely inconsequential in a 25-year-old can have meaningful consequences at this stage of life. Testosterone production begins declining gradually in men starting around age 30, at a rate of roughly 1 to 2% per year. By the mid-50s, many men have testosterone levels that are 30 to 40% lower than they were in early adulthood. This decline, sometimes called andropause, though that term is debated, affects libido, erectile quality, ejaculatory function, and sensitivity. At the same time, vascular health typically declines with age. The small arteries that supply blood to the penis are susceptible to atherosclerosis, hypertension, and the effects of metabolic conditions like type 2 diabetes, all of which become more prevalent after 50. Erectile function is directly dependent on vascular health, so the baseline reserve is lower. What this means clinically is that the sexual system in a man over 50 has less resilience and less margin for error than it did 2 or 3 decades earlier. Behavioral habits that place additional stress on that system, particularly patterns of excessive or dysregulated masturbation, interact with these physiological changes in ways that compound the problem. That's the context. Now let's look at the specific mechanisms. The first and most commonly discussed risk is erectile dysfunction, and the mechanism here involves both the brain and the body. On the neurological side, frequent masturbation, especially when paired with high-stimulation pornography, can trigger a process of desensitization in the brain's reward circuitry. The dopaminergic system, which governs arousal and reward, is activated intensely and repeatedly. Over time, with chronic overstimulation, the system downregulates. It becomes less responsive to ordinary levels of stimulation. The clinical result is what's sometimes called psychogenic erectile dysfunction, where a man has no structural problem with his vasculature or his hormones, but finds that real-world sexual situations don't generate the arousal response they should. The brain has been conditioned to respond to a level of stimulation that a partner simply cannot replicate. I covered the neuroscience of this in detail in a previous video on pornography and sexual dysfunction. I'll link it below. But the short version is this: the brain is plastic. It adapts to repeated inputs. Give it unusually intense stimulation over and over again, and it recalibrates around that level as the new baseline. Now layer that neurological pattern on top of the physiological changes we just discussed: reduced testosterone, compromised vascular health, lower baseline erectile capacity, and you have a situation where behavioral habits are actively worsening an already challenged system. For a man in his 30s with healthy testosterone levels and clean vasculature, this kind of desensitization may resolve relatively quickly with a behavioral reset. For a man in his 50s or 60s who already has some degree of vascular compromise, the recovery is slower and the functional impact is more significant. The key variable isn't masturbation itself, it's the pattern. Occasional, moderate masturbation without high-stimulation pornography dependency is not the concern. The problem is frequency, intensity, and the attachment to stimulation that can't be replicated in real sexual encounters. The second risk area is premature ejaculation, and the mechanism here is less about brain chemistry and more about behavioral conditioning. Ejaculation is, at a fundamental level, a learned neuromuscular response. The timing of ejaculation can be trained toward faster or slower responses through repeated experience. This is the basis of most behavioral therapies for premature ejaculation, which use techniques like the stop-start method or the squeeze technique to gradually extend ejaculatory latency. The problem with habitual rapid masturbation is that it trains the opposite response. When masturbation is consistently performed quickly, often in contexts of privacy or time pressure, the body is repeatedly conditioned to reach ejaculation in a short time frame. The neuromuscular pattern gets reinforced with each repetition. Over time, that pattern becomes the default. For men over 50, this behavioral conditioning interacts with a natural age-related change. Ejaculatory latency, the time between initiation of stimulation and ejaculation, tends to shorten with age. The neurological threshold for ejaculatory reflex decreases. So the combination of an already reduced latency and a habitual conditioning toward rapid ejaculation creates a compounding effect that can significantly worsen premature ejaculation. The inverse of this is also true, and it's important to understand. Men who masturbate with attention to pace, who practice awareness of their arousal levels and deliberately slow down before the point of no return, are actually engaging in a form of self-administered behavioral therapy. The habit itself isn't the problem. The pattern of that habit is what matters. For men who recognize this pattern in themselves, working with a urologist or a certified sex therapist to implement structured behavioral retraining is effective. This isn't a fixed or irreversible condition, it's a conditioned response, and conditioned responses can be reconditioned. The third risk area is one that gets significantly less attention than erectile dysfunction or premature ejaculation. But it's a real and increasingly recognized problem. Anorgasmia, or delayed orgasm, and in more severe cases, complete inability to reach orgasm during partnered sex. The mechanism overlaps with what we discussed in the erectile dysfunction section, but it's distinct. Where desensitization in the erectile context affects the ability to achieve and maintain erection, in the orgasmic context it affects the ability to reach climax. The brain has been conditioned to expect a very specific type of stimulation, a particular pressure, grip, intensity, or visual context, that is not present during sex with a partner. This is sometimes called death grip syndrome in online communities, and while that's not a clinical term, it describes a real phenomenon. When masturbation consistently involves a level of physical pressure or a specific technique that cannot be replicated during intercourse, the orgasm threshold shifts to a point that normal stimulation can no longer reach. For men over 50, this is compounded by age-related changes in genital sensitivity. Peripheral nerve sensitivity in the penis tends to decrease with age, a natural consequence of vascular and neurological changes. This means the baseline for orgasmic sensation is already lower. When dysregulated masturbation habits further elevate the stimulation threshold required for orgasm, the gap between what the body needs and what a real sexual encounter provides can become very wide. Men experiencing this often find it deeply confusing and distressing. They may be able to achieve erection, they may want to have satisfying sex, but they simply cannot orgasm with a partner even after extended effort. This can put significant strain on relationships and self-esteem. The good news is that, like the other patterns we've discussed, this responds well to behavioral intervention. A structured period of abstinence from solo stimulation, followed by gradual reintroduction with attention to varying technique and reducing intensity dependence, is the core of the recovery approach. A certified sex therapist can guide this process effectively. Beyond the direct physiological effects, there are psychological and relational consequences worth addressing honestly. The first is guilt and shame. Many men who recognize that their masturbation habits have become dysregulated experience significant distress about it, and that distress itself can worsen sexual function. Performance anxiety, self-monitoring during sex, and anticipatory worry about erectile or orgasmic failure are all psychological mechanisms that directly interfere with arousal and sexual response. The shame compounds the clinical problem. The second is social and relational withdrawal. When masturbation, particularly masturbation paired with pornography, becomes the primary or preferred sexual outlet, real sexual encounters with partners can start to feel less appealing, more effortful, or more anxiety-provoking by comparison. Over time, some men find themselves avoiding partnered sex, not because they don't want connection, but because the gap between what they've conditioned their brain to expect and what real encounters provide has grown too large. This withdrawal pattern can cause significant damage to intimate relationships, and it can also create a feedback loop where isolation reinforces the behavior that caused the problem. None of this is said to generate guilt or alarm. It's said because recognizing these patterns is the first step toward addressing them, and because these are solvable problems when approached with the right professional support. Let's close with the constructive part, what to actually do about this. First, practice moderation and intentionality. There is no clinically established number of times per week that constitutes excessive. That threshold varies by individual. The relevant question is whether the habit is interfering with partnered sexual function, relationship satisfaction, or daily life. If the answer is yes, that's the signal to recalibrate. Second, reduce pornography dependence. High-stimulation pornography is the primary driver of desensitization in most of the patterns we've discussed today. A deliberate period of reducing or eliminating pornography, while still allowing moderate solo sexual activity, is often sufficient to begin restoring normal arousal responsiveness. The brain's plasticity works in both directions. Third, invest in overall physiological health. Erectile function, ejaculatory control, and sexual sensitivity are all directly tied to cardiovascular health, testosterone levels, neurological function, and metabolic status. Regular aerobic exercise, a diet that supports vascular health, adequate sleep, and stress management are not peripheral recommendations. They are foundational to sexual function, particularly after 50. If testosterone levels have not been checked recently, that's a conversation worth having with a physician. Fourth, seek professional support without waiting. Urology and sex therapy are the two professional disciplines most equipped to address the concerns covered in this video. A urologist can assess the physiological contributors, vascular health, hormone levels, neurological function, and rule out or treat organic causes. A certified sex therapist can address the behavioral and psychological dimensions with structured, evidence-based approaches. These two tracks are complementary, and the earlier they're engaged, the better the outcomes. The core message of this video is not that masturbation is harmful. It isn't. When practiced in a balanced, intentional way, it's a normal part of sexual health at any age. The message is that the body changes after 50, and habits that have a lower impact in younger men can have a measurably higher impact as the physiological reserve decreases. Understanding those mechanisms, desensitization, behavioral conditioning, sensitivity changes, allows for informed choices rather than confusion or shame. Sexual health is health. It deserves the same honest, evidence-based attention as any other system in the body, and the problems covered today are not permanent, not shameful, and not beyond the reach of effective treatment. Subscribe for weekly urology and sexual health content. I'm Dr. Claire Hayes. See you next week.